Yeah, on you go.
So hi everyone, my name's Stephanie. I'm one of the IMT doctors at Stepping Hill, and today Graham's going to do a talk for us on failure to thrive in preparation for your OSCEs. And I've kindly also got Kareen, which is one of my colleagues who specialises in paediatrics, to answer any questions that come up. So I'll take it away, Graham.
Thank you very much. Before we start, can I just get everyone to put in the chat which year they're in? I'm assuming most people here are fourth years because they're exams, but just to double check. And just while you do that, I will introduce what we're going to do. So I'm going to take you through a case today on failure to thrive. I think it's important during the whole time just to bear in mind that this will be a very specific case, but what you can take away from it is how to kind of adapt that to the station that you get, and always to bear in mind that your age group is very, very important in this presentation, but we'll cover that a bit more as we go through. So first, just a reminder of how to do a pediatric history. It's slightly different. I'm sure you're all aware of what to do here, but just to double check. So obviously you want to start with your presenting complaint and your history presenting complaint and your past medical history like normal. I tend to put it wherever you want. As long as you've got a structure that works for you and you are including everything, that's absolutely fine. But I find that putting this in your past medical history works quite nicely for me, especially in OSCEs. It's just to include, kind of start from the start, if you like. So start before they're even born. You want to ask the mother, particularly if there are any issues prenatally, or whether do they have any problems getting pregnant, any risk factors for anything essentially. So diabetes is a big one, smoking, all of those questions, which I'm sure you're all aware of. Any problems during pregnancy, any problems at birth, and any problems in the postnatal period. And that should cover everything really. It's nice to just get that nice chronological order. Kind of shows where your thinking is in a auscultation. Then the classic, ask about immunizations, ask about their nutrition. So how are they feeding at the moment? How are they feeding? Are they getting the same number of wet nappies? Are they still producing dirty nappies? Any change in their stools? That kind of thing. You can, in an OSCE situations, particularly in this kind of scenario, when you're asking about development, all you need to do is just ask, have you had any issues? Have you noticed any issues with their development? You might want to clarify that you don't just mean their weight, because we're obviously talking about failure to thrive in this situation. You want to ask them, any problems with a motor or anything like that. But you'll be able to adapt that to the situation. And then social, just essentially what are they being exposed to? So kind of smoking. Neglect is a really difficult thing to ask about. I've come across a few phrases that you might find useful. So kind of asking, how are you finding looking after X? How are you finding bonding with your baby? That kind of thing can sometimes prompt SPs in particular to give you a bit of information if that is something that is part of the history, but they're not trying to hide anything from you. So if it is a safeguarding history, it will probably be fairly obvious that that's the route that you've got to go down. And then just a way to remember that is BINDS. If you're a Manchester student, I'm sure you've come across this. It's just birth, immunizations, nutrition, development, social. And then obviously don't forget about drug history, which includes allergies, and family history is very important, especially with very young babies. Okay, on to the next one. So just a tip, that's obviously a bit of a checklist. They're very useful and give you a bit of structure, but don't rely on them. Always try to think, why am I asking this question? What am I trying to find out by asking that? And where is it going to take me? If you just ask a list of questions, you're likely to pass. If you want to get higher marks, really try and make it clear that why you're asking the questions. It shows a deeper understanding. And we'll cover that a bit more when we get onto the actual case. So first of all, you're just going to get a bit of a brief history. So you got this 5-month-old male. He's presented to his GP. This may also be a reasonable presentation that you might get in a pediatric assessment unit. The parents are concerned about his growth. Now, an important thing to mention here is the fact that the parents are concerned. A lot of people don't realize that is actually a red flag. Never dismiss concerned parents. obviously you will get quite a few parents who are concerned about their child who's actually okay, but it's always a red flag. It's always a reason to delve in a bit more about that history. There's no past medical history of no issues around birth. They're fully vaccinated. He's got a 7-year-old sister who's fit and well, and she's had no issues of growth. Can you put in the chat now anything else that you'd like to know, bearing in mind what we've said already? There aren't any wrong answers. Just say whatever you think. It's always easier. These are always easier if we're as interactive as possible. So yeah, if you want to put in the chat, feel free. Otherwise, you can unmute your mic, whatever you're comfortable with. So the concerns about their growth, that's the main thing. Nice. So yeah, Karen said height and weight centiles. So yeah, we want to know, is there actually a problem with their growth? Have we been getting measurements? Feeding, absolutely, that's a big one. Are they getting their nutrition? Developmental milestones, we'll definitely come on to that. That'll definitely be part of it. Behavior, Mustafa said that's a really good point, and it can tell a lot about a pediatric history in their behavior. You're expecting them to be, if they're 5 months old, they might not be running about, but they'll be pretty alert. They might be annoying their parents, they might be crying. It's not going to be a very nice situation being in an unusual environment in the GP, so they're probably not going to be too happy about that, but they're going to be loud and noisy probably. If they're kind of drowsy or tired, that's something to worry about, absolutely. So continue the history. So feeding wise, it's good to start at the start if you like. So why are they worried about their feeding? That kind of comes into ICE, if they offer the fact that they're worried about something, go straight into asking them why they're worried, what are they concerned about. So they're exclusively breastfed. The mums noticed that it can take about 2 hours to feed. It used to take kind of 20 to 30 minutes, so it's clearly quite a big change. And he gets really pale and bluish and clammy and even breathless when trying to feed. Although she can see him swallowing, so it's not an issue of swallowing, it's that he's getting breathless. Does that make anyone think of anything at the moment? Any possible routes that we want to go down? Cardiac cause, yeah, absolutely. Any other causes that could be? Or any other ideas at the moment? Bronchiolitis, yeah, definitely. So a respiratory cause could be any real primary respiratory disease. They're breathless. First thing that makes you think of is lungs. And cardiac, yeah, good ideas. There's no changes in their stool, consistent color, and no excess vomiting. So when I'm doing a failure to thrive history, especially in an OSCE, like I keep saying, you want to have that structure. A good way I like to think about it is start from what goes in and finish with what comes out. Are they getting their nutrition in? That's their feeding. What's happening in the middle? Are they vomiting? Are they having any projectile vomiting straight after feeds, like a pyloric stenosis? Then coming out the other end, what are the stools like? Are there any pale stools like a biliary atresia, or any blood colored stools like an IBD, or maybe a bit older, kind of thinking celiac disease? The fact that they're exclusively breastfed, I wouldn't be worried about celiac disease, but that's, tailor your history to your patient. The nappy's not being changed so often, so maybe suggest that they're a bit dehydrated. Although they're not getting any intake or as much intake in, so that makes sense. They're not going to produce as many stools. It's just pretty self-explanatory. In terms of the behavior change, we mentioned that already, is a good point. They're much more sleepy, much less hassle getting into bed, which might seem like a good thing, but it's definitely a red flag, especially in a child this age. He seems to get tired very easily. No obvious developmental delay noted. Anything else anyone would want to know at this point? Anyone can think of, just pop in the chat. Just a quick top tip here in terms of failure to thrive cases is that the vast majority, I think it's about 95%, it's problems with feeding. So you really want to delve into that a bit more. It's quite easy to, it's relatively easy to establish feeding technique, as opposed to starting to go straight into lots of investigations like taking bloods. We don't want to put any you don't want to distress the child in any way. So do the least invasive thing first, which is check and feeding technique. Some places have nurses that are probably best suited to doing this, depends where you are. Always ask, are they just breast milk fed, or is it formula feed? If it's formula feed, it's a bit easier to quantify because you can actually measure in mils. I never learnt this for my exams, but it's something that you may want to know about the 150 mils or 100 mils per kilo per day. You can only use that for formula though, obviously. In terms of breastfeeding, asking if you can see them swallowing, are they, and then the NHS website is actually really useful for revision as well about breastfeeding, and kind of things you need to know about that. And is this normal? What's the parent's height like? And is it actually an accurate measurement? So we want to measure them today. I don't know if you want to say anything at this point, Kareem, with regards to what we've talked about so far. Anything else you'd want to mention?
Yeah, no, I think that's a very good summary. I think in terms of specific to Manchester exams, I think you're completely right in terms of saying that the simulated patients will prompt you.
Yeah.
So if you're just really clear with your ideas, your concerns, and your expectations, and if you're not 100% sure exactly what is going on, that more often than not, the SPs will give you a hint, or will sometimes even tell you, oh, I've been doing some research online and I know that conditions with the heart can cause difficulties feeding, things like that. Or you're completely right in terms of saying things like neglect, which is maybe not, I think we tend to often go immediately thinking about medical causes for things. And in pediatrics, the social causes are actually really, really important not to miss. So things like neglect, if a parent, and it might not be something that is malicious, it might just be, like you were saying, something that is like a parent who's struggling, and if they're a first-time parent, and we see a lot of babies come in and they're first-time parents and they don't know how much babies are supposed to be. Not so much in this case, they're 5 months old, but if they're only a few days old, parents don't know exactly how much they should be taking. Often mums aren't actually producing a lot of breast milk within the first couple of days, and they think that baby is feeding really well, but they're not actually getting they're not actually getting enough milk for them. But yeah, and in terms of knowing like the mils per kilo per day, as a child gets older, that becomes less relevant. Absolutely, in the neonatal periods, you want to know, how many mils are they actually getting. But kind of after that 28-day point, it becomes there's kind of it's less structured at that point.
Yeah.
Main things you want to be asking is, are they opening their bowels frequently? Are they passing urine frequently? Those are the main questions in practice that we would use to kind of clinically assess how many nappies are they wetting or dirtying a day is really useful, because often parents will know that if their child is wetting 10 nappies a day and then they've gone down to one or no nappies, and that's a pretty big indicator that they're either not getting enough in or there's some other issue going on.
Yeah, thanks, that's great. On to the next slide. So just in terms of a bit more of their past medical history, not really been any major issues. The only thing of note is the mum has type 2 diabetes. The only medication that she's taken for that is metformin. She's not on any other medication. She does have a BMI of 30. It says that all scans have been normal so far. He was born at 40 weeks, so term. A very normal weight, and no issues during birth or neonatally. This is maybe quite a hard question, but can anyone think of maybe a problem with the fact that the mother's overweight and that their scans have been reported as normal? I don't know. You might be seeing where this is going. If you do have an idea, put it in the chat and we can see. Otherwise, heel prick's normal. Well, that's a good sign in terms of metabolic diseases. You'd be unlikely to get an inborn error of metabolism as like diagnosis in OSCE, but it's another thing to bear in mind that could be a problem. It could be a cause of failure to thrive. So things like PKU, maple syrup urine disease, that kind of stuff is very rare, but something to put in the back of your mind if you like. Now we've got the growth chart here. I imagine no one here probably wants to interpret it, but if anyone does, do let us know. I kind of put this together, so it's a little bit just put together to make it easy for the presentation, but it's a reasonable thing to get in an OSCE. Failure to thrive comes up all the time, and I've had it in the past, and they will give you a growth chart that looks something like this. First thing to always do is make sure it is the right growth chart. So this is a boy and he's under 1 year. Yes, someone said already that the weight is clearly an issue here as they've crossed some centiles. Notice that their head circumference, they've started right bang in the middle, 50th centile, and that's been preserved. That's fairly typical of this situation. The length's also been preserved, but their weight has started to level off, and you see it's crossing these centiles, so these lines here. If anyone's not sure what we mean by that, please do put it in the chat and we can explain a bit more. This kind of picture, the fact that the head circumference has been preserved, their length is on a decent trajectory, but their weight is starting to falter, is pretty classic of the fact that there's an increased metabolic demand somewhere. Now that could be a whole multitude of things. It shows us that they don't have congenital short stature, which can sometimes be confused for failure to thrive, because their length is preserved, but their weight is coming down. So that's really important there. If anyone's got any questions about that, please do put it in the chat, because that's really important to be able to interpret a growth chart. I don't think they've ever asked you to plot a growth chart, but this is another thing that they could ask you to do. You can find this here. I think it'll be on one of your cases, and if not, if you just type in the WHO growth chart, the WHO growth chart, you'll be able to find it. So now onto the examination. So first of all, in general inspection, you've been told, you can see that the baby is drowsy, it's lying in the mother's arms. It's clearly struggling to breathe, and it's breathing quite fast, but there's no obvious cyanosis just sitting there. So it's not a blue baby, it's a pink baby. And of course, inspection, the only thing I note is a single palmar crease. If anyone wants to put in the chat what that means, please do. Otherwise, we'll keep going. In terms of the respiratory system, they've got they're tachypneic, they're hypoxic at 86% on air, and they're subcostal and intercostal recession and nasal flaring. Now, these 3 points here, I'd recommend you type this into YouTube just to see what they're like. If you haven't seen that before, that's a really important sign. Yeah, Jess has said Down syndrome is a possible reason for the single palmar crease, which could be quite important in this case. That's absolutely right. Normal percussion, no added sounds on auscultation. So they're clearly struggling for breath, but we kind of knew that a bit for the history anyway. But they are hypoxic, so that's very, very important. Their cardiovascular system, their cap refills, that's okay, but they're a little bit tachycardic. You will be given the normal values if you are given kind of things like heart rate and respiratory rate for peds, because they do vary for different ages. There's a pansystolic murmur heard over the precordium, and it's not very loud. If you're not sure why that's important yet, have a little think about why it may not be loud in this case and what that could mean. But keep it to yourself for the moment, and we'll see what that turns out to be. In terms of their abdomen, there's no abnormalities. The bowel sounds are present, soft, non-tender. So it doesn't seem to be a problem with their gastrointestinal system, but could still be a reasonable differential. Neurologically, maybe a bit of hypotonia, maybe a bit drowsy. And then ENT is normal, always do an ENT exam in peds, or always offer to at our age, because every child might have an infected eardrum or tonsillitis and stuff like that that's causing their presentation. And then derm, again, in peds, you would never want to miss a meningococcal rash. And and you don't want to miss any signs of non-accidental injury. So kind of bruises where there shouldn't be bruises. Definitely something to look up how to interpret those, because it can be quite difficult. I don't think you'd get that in an OSCE, but it's something to bear in mind. So yeah, keep those things in mind. I've highlighted the problems with the drowsy, problems with breathing. They've got increased work of breathing. That's what this is a sign of. They're tachycardic, and they've got a pansystolic murmur, and a syncopal crease, which may be incidental, maybe nothing. In terms of the observations, here they are here. So the abnormal ones are up here, and they're drowsy. Temperature is 37 degrees Celsius. So we're probably not thinking an infection here. And that's a really important point. Do note that that doesn't mean there's not an infection. They may be spiking temperatures at different times. You may have caught them at a time where they're not having a temperature, but it does decrease the likelihood of a infection being the cause of this presentation. But don't dismiss it. You never want to miss sepsis. So just for some differentials, we've put some here. I'd say if anyone's ever short of breath, pediatric station, adult station, whatever, I would always have anemia as a differential. It's just a very easy one to rule out, and it's a definite cause of shortage of breath. Now, this could be heart failure. We've already mentioned it could be a cardiac cause. And I've put here a VSD for the murmur. Can anyone think that why, if it is a VSD, so ventricular septal defect, why that might be quiet, or I said it wasn't loud? What's the importance of that? Any ideas? Otherwise, we don't think it doesn't seem to be any obvious trigger for a decompensation to heart failure like an infection. Down syndrome is definitely associated with cardiac abnormalities. The big one that's associated with is an atrioventricular septal defect, which is a cyanotic heart, which causes cyanotic heart disease as opposed to acyanotic. We'll come to what that means in a little bit. But it's definitely can be associated with just a VSD on its own. We mentioned already primary respiratory disease. So it could be a bronchiolitis or pneumonia. We've already mentioned that. They're potentially in shock. If you look at their observations, they've got raised respiratory rate, their heart rate, although their blood pressure is okay, but bear in mind that, especially in kids, blood pressure is kind of the last thing to go. If you've got a hypotensive child, it's really, really panic stations, because they're able to maintain their blood pressure to a very, very late stage. So another reason to kind of catch sepsis early. But no pyrexia makes it less likely, but it doesn't get rid of it, like we already said. They could be hypovolemic, and that could have caused their tachycardia. They might be hypovolemic because they're parentic. They might be hypovolemic and one of these other things. And I'll also check any signs of blood loss if you're checking hypovolemia. It could be a metabolic thing going on here. Are they short of breath because they're acidotic, causing them to want to blow off CO2? We'll come back to why the VSD, if they do have a VSD, if it's why quiet is an important point there. In terms of bloods, we're going to do some bloods. I should probably have asked you what you wanted to do, but they're there now. So, I mean, you're always wanting to do an FBC. In an OSCE, you're probably going to want to do it in pretty much every situation, but always try to think, why am I ordering this investigation? What am I looking for? So we've already mentioned anemia. So we want to check their hemoglobin, and we want to check the white blood cells. Just, you can rattle that off in an OSCE very easily. You always have to have a reason why you're doing, what you're looking for. Don't just do tests for the sake of doing tests. Using these, check for an AKI. They could be dehydrated. LFTs, they could have right-sided heart failure. They could have an infection. They could have liver disease. That could be a cause of the failure to thrive. You can get away with asking those things. They could have hypoalbuminemia that could cause, because they're not being nourished, they're not getting the right nourishment. CRP, because is there an inflammatory process going on, like an infection again? Glucose, is it diabetes? It's very rare to get at this age, but the mother has a type 2 diabetes. You'd maybe expect them to have low glucose levels at birth if the mother's diabetic, but at this point you'd expect that to be corrected, but worth doing nonetheless. Blood cultures, you just don't want to miss sepsis, especially in this age group, because they decompensate really quickly. Same for urine dip, urine culture. And you can also do some metabolic studies of urine. You could put that in. I don't think many examiners would expect you to say that, but if you wanted to get those 5 out of 5s. Lactate, they've got signs of shock, you want to check that. Ammonia, that comes in the metabolic diseases, and a capillary blood glass. So you wouldn't do an ABG in this scenario because it's a 5-month-old. So we tend to do a CPG, and you're looking for, signs of shock. You could check their lactate, you could check their oxygenation. We'll come back to that. We've done an ECG, just sort of sinus tachycardia. The chest X-ray is normal, which when we come to the diagnosis, some people might find a little bit odd, but we can explain that. And the echo, you're awaiting the results. I would spoil things. So can anyone say why you might see abnormalities in their LFTs, their CRP, their glucose, lactate, CBG? What are you expecting to see? I want to get you into the mindset of thinking, not just thinking, oh, I need to do an FBC, Ks and Es, LFTs, etc. What are you looking for? So these are abnormal in this case. Can anyone say why they might be abnormal? You can choose anyone. I'll wait for you to say. And anything else you want to say, Kareem, at this point?
Yeah, I mean, I think it's a very thorough kind of plan when you're saying. I won't kind of talk about the investigations and stuff, but yeah, I mean, things like metabolic studies of urine, you probably wouldn't do when they first came in,
yeah.
Like you said, and things like ammonia as well, you probably wouldn't do initially. In terms of in practice, I think it would be a very brave doctor who didn't treat this baby for sepsis, even if you didn't think that was the first. Even despite them not having temperature, any floppy baby, like a child looks at you wrongly, they get treated for sepsis.
Yeah.
Like it's in practice, I think they definitely would be, but before you got other investigations back. But yeah, I mean, I wouldn't do anything differently than what you've put down.
And they're to pass. They're not looking for someone who's got the diagnosis right, got the management exactly right, got everything right. They're looking for someone that's safe, and the safe doctor treats for sepsis and asks for help.
Yeah, absolutely. Yeah.
So we'll go on to the results. The exact values here don't really matter. I just want to get you guys thinking, what you're expecting from these results, and what does it mean? Why is it there? So for the LFTs, the transaminases, the ALT/AST, slightly raised. Is that a sign of right-sided heart failure, a bit of congestion? Might be unusual in this age group, but is that what's causing that there, or is it just slightly raised? Do we need to get more results? CRP and glucose slightly raised again. You'd expect that in a stress response. If you're getting sort of a glucose of, I don't know, 7.1 or something like that, the baby's going to be stressed. They're going to be releasing cortisol. It's going to increase their glucose. Just like if an adult had a heart attack, then their glucose goes up from a stress response, and their CRP is going to be slightly raised, but it's not through the roof, which is important. So there's not like an abscess somewhere that you're missing, or there may be, but it makes it less likely. Their lactate slightly raised, which may point towards a kind of hypoperfusion of tissues. Is that why the patient's drowsy? They might be, they're not pumping enough blood to their brain, they're not pumping enough blood to elsewhere. Do they feel cold peripherally? What are you going to do now from that? And their CBG, they've got type 1 respiratory failure, so a low PO2, but a normal PCO2. Normal to low, so they're probably blowing off some CO2 in response to a slight acidemia, so their pH is kind of normal to low there as well. So it's not like they're different to adults in that, you know, if you're getting an adult that's drowsy, they're hypoperfusing their tissues, their pH is, in this situation, is probably going to be markedly down, and their CO2 is going to be low to normal as well. If that makes sense. If anyone's not sure, do say. So anyone have any suggestions for what the most likely diagnosis is now, and any other diagnosis that you think there would be? Just bear in mind what we've said already. And again, Kareem, I don't know if you've got anything to say about those results.
Yeah, absolutely. I mean, I think in terms of the stress response with the glucose, again with CRPs, you know, you're always wanting to rule out things like infection, but CRP is such a non-specific marker that absolutely could be raising other things. And then, yeah, lactates being raised. Yeah, I mean, in terms of doing blood gases, I think it wouldn't be out of the question that the if it was like an interpretation station, and some of the OSCEs that I've examined this year, there's been an interpretation station where you basically just get like a quick blurb about the patient and then results that you have to interpret. So so like a capillary blood gas or an ABG would definitely be something that they would expect you to be able to interpret and talk about. So if you don't feel comfortable about looking at those, probably worth having a quick read. Just, you know, simple things like type 1 and type 2 respiratory failure, raised lactates, you know, the main things that you wouldn't want to miss, really.
Absolutely, yeah. I'm just giving everyone a little reminder. So just their presentation, 5-month-old, they're struggling to grow. When they feed, they're turning pale, bluish, clammy, breathless, but they're swallowing, not as many wet nappies. They've not had any problems in the past. You can see that they're struggling to breathe, they're a bit hypoxic, and they've got a murmur. Someone said tetralogy fallow. That's quite specific, but I think you're on the right lines of it's a cardiac cause for sure. Yeah, Karen, would you like to say why you think it's a large VSD as opposed to a small or you know, any other size of VSD? Why did you say large in particular? You're right. Quiet murmur, exactly. And we'll come on to why that is in a second. So I think in this case, you know, it was set up to be a VSD causing heart failure. I've left it relatively vague just because it doesn't really matter what the diagnosis is in this case. It's more trying to get you to think, how are you going to tackle this kind of station? And bearing in mind that you're probably not going to get a congenital heart disease as a station, but it's definitely could come up. It's one of the cases. Anything that's a case can come up in your exams. Other things to bear in mind, quite common in exams, would be, you know, poor intake. Always ask about feeding. Infection, sepsis, like we said, trying to hammer on that home. Celiac disease comes up, I think, every like 3 years. It seems to come up all the time. I had it this year actually in my finals, but you'd expect, but that obviously wouldn't be in this case because this child's only having breast milk. You'd expect them to introduce solids around 6 months. Things tend to match up with their change in diet. People often say lactose intolerance at this age, you know, if there's problems with their bowels. Be really wary of saying lactose intolerance because congenital lactose intolerance is incredibly rare. It's much more likely to be something like cow's milk protein intolerance, especially, you know, if they're on formula. And that's much more common in under 1-year-olds, so that could be in this situation, but obviously there wasn't anything wrong with their bowels. And then congenital abnormalities, less likely, but possible. The main ones are poor intake, sepsis, celiac disease, cow's milk protein intolerance. Again, just really be wary of saying lactose intolerance. Do you think that's fair to say, Kareem?
Yeah, you're completely right. You know, congenital lactose intolerance is very rare. But you know, things like cow's milk protein intolerance is so common.
Yeah.
But like you said, in this specific case, There's nothing that's suggesting that other than the failure to thrive. But it definitely, it definitely could be something that could come up in exams. You'd be looking at kind of bowel symptoms, other allergic symptoms like rash, vomiting, things like that. But yeah, absolutely, I completely agree.
And if anyone's not aware, people tend to get lactose intolerance following gastroenteritis, and that's the most common way in which you get lactose intolerance. And just remember, you don't always get this when you walk into a station, but you will probably get the age of your patient before you walk in, and some brief thing about checking a growth chart, stuff like that. Always think what's most likely in this age group, because it varies massively. You go from a 1-month-old to a 5-month-old to a 1-year-old, 3-year-old, a 16-year-old. Failure to thrive is technically under 3, but you still might get problems with growth in a station. But really think what's most likely in this age of a patient. Now just a few things about VSTs, just for those that are interested. So anyone know why you hear pansystolic murmurs? So just for the sake of time, I'm just gonna say, let me make this red. Hopefully that comes through. Yeah. So where you're thinking, where's blood traveling during systole, there's a defect in the ventricles. There's nothing going on in the atria, so you'd expect to hear something during systole when the ventricle contracts, and instead of blood going up here and up through the aorta on its own, it's coming through here and up through the pulmonary valve. This is an important thing. I didn't realize this when I was in 4th year, that I mean, it's pretty obvious when you draw it out, but the blood is going up through here and into your pulmonary valve. Think where are the pressures high? The pressure's the highest in the left ventricle, so blood's going to move this way into a lower pressure system. I've put here, why may pulmonary stenosis be protective? It kind of helps equalize the pressures. If you think, this valve is stenosed, it's going to be harder for the left ventricle in a sense. Can you see my cursor, by the way, Karen? Yeah, good. So yeah, if it's coming up here and this is stenosed, then the left ventricle is, in a sense, going to be working against that pulmonary stenosed valve, which is going to equalize the pressure. So you're not going to get as much blood going up here. If you're getting lots of blood going up here, you're going to get pulmonary hypertension. If that's left untreated, you get a thing called Eisenmenger syndrome, which is a reversal of a left to right shunt to a right to left shunt, which is a cyanotic heart disease, which is very important. I'll come on to that in a second. We've already said, why is the murmur not loud? It's because it's a bigger defect. Larger defects, obviously, common sense dictates that they're going to be of more concern. Very small defects, actually, they might go unnoticed their entire life. They often just resolve themselves with growth and don't need any intervention. A large defect, though, will probably need an intervention, but you don't need to worry about what that actually is at this stage. Yeah, so remember that this case was relatively simple. In practice, you're always looking for a coexisting pathology. So I mentioned TOF, or tetralogy of Fallot. I won't go into too much detail of this just for the sake of time, but looking for, trying to listen to pulmonary stenosis, check for a PDA. PDA is really important in cyanotic heart disease. Here we go.
Can I just add in here? So I think
yeah.
Ahmed put in, patients with VSD, pulmonary stenosis protects them from developing pulmonary hypertension.
Yeah.
And I suppose if you go back to your well, you don't have to go back, but looking at the investigations, the ECG in this case was sinus tachycardia. But I suppose a sign that things are worse would be if there was signs of right heart strain on the ECG. So that's just something else to bear in mind, like right bundle branch block, right axis deviation, etc. So that's just something else that might, I don't know if they would say that about the ECG findings, and something else to consider when you're saying you would do an ECG, that you would be looking for signs of right heart strain.
Yeah. The only other thing that I would say is that if you've got pulmonary stenosis, is generally a more significant problem than a VSD. So you're right in saying that technically, if you had a very large VSD and you had pulmonary stenosis, then it would increase the pressures in the right ventricle, which would then counteract the increasing pressures of the left ventricle. But the actual pulmonary stenosis, as well as that, would be reducing your blood flow through the pulmonary artery to the lungs. So that's generally, I would say, is actually probably a more significant problem than the majority of VSDs.
Yes.
But
Yeah.
I'd be careful in saying that it's a pulmonary stenosis.
Yeah. That's a very good point. More just to illustrate the
Absolutely.
pathophysiology of whoops, Daisy, of why you get pulmonary hypertension.
Yeah.
So and just for everyone's sake, it protects against pulmonary hypertension because you're not getting as much blood going through that system. So you're not going to get the pulmonary hypertension, but pulmonary stenosis is, like you say, a very, very significant finding. Great. I'll try and rattle for these. If anyone wants these slides later, just send me an email. I've got my email at the end. I've just put in a couple of things just for revision. Oh, I don't have time to ask this, but pansystolic is the same as holosystolic. Just a little note on acyanotic versus cyanotic heart disease. Remember, acyanotic is a left to right shunt, so blood is going from the left side to the right. So this is oxygenated blood mixing with deoxygenated blood, which is usually found within your first year. Cyanotic heart disease is different in that you'll probably present at birth with a blue baby. But remember that acyanotic heart disease can transform into cyanotic heart disease, that Eisenmenger syndrome, and that's the point where you don't want to get to. It's incredibly rare in the developed world because patients tend to get these significant defects found when they're quite young, and they will have monitoring, they'll have interventions. They won't get to the point where they get Eisenmengers. That's a bit of a thing of the past, but that's the reason that it's so important. These, if you're going to know any acyanotic heart diseases, no VSD, ASD, PDA, really important, particularly in cyanotic heart disease. Beware of O2, if anyone knows what that is. It's because oxygen can cause closure of the valve. You don't need to worry about that as an F1. I don't think you'd come across this situation, but for your exam's sake, particularly MCQs, and you give prostaglandins, or is it NSAIDs, sorry, to keep it open. I may be wrong. It's one of them. I would double check that.
Prostaglandins keep it open, and it's usually paracetamol, ibuprofen that you can give to close it.
Nice one, thank you. And then in terms of cyanotic heart disease, just remember these three. There are multiple. Epstein anomaly is really common in progress test. So if the mother's getting taken lithium, that can cause an Epstein anomaly, which is a problem with their tricuspid valve. But keep it simple. If you're going to mention any, just mention a couple of what you think it could be. Obviously, I don't think you'd get a cyanotic heart disease in an OSCE, but it's useful to know which ones are cyanotic, so you don't mention them in that case, and you know kind of what you're talking about, because they typically present at birth. And then there's some obstructive things, so I'll just leave these here for you if you want these slides. Some chromosomal conditions to be aware of. I think everyone's aware of Down syndrome, but remember Edwards and Patau's, there's a couple of other differentials. They're particularly useful for your MCQ exams. Don't worry too much about them for your OSCEs. And here's some resources if you do want the slides. Oh, someone said the AVSD is...
Oh, sorry. If it is a question on the exam, I think Edwards is trisomy 18 and Patau's is 13.
Oh, my bad. I'll change that for the slides before I send them out.
I think I think it's just for like a progress test question.
Yeah. Someone asked why AVSD, so atrioventricular septal defect, is cyanotic, but ASD or VSD is acyanotic. So first of all, VSD can be cyanotic if it's large enough. So if there's enough mixing here, without going into the semantics of it, if it's a very big VSD, it can be cyanotic. ASD is going to be a less significant lesion. If you think AVSD is going to be, for the same reason that a VSD can be cyanotic, it's a huge lesion. So it's going from your atria down into your ventricular septum. I wouldn't worry too much about that. If you're interested, if you look on YouTube, there's some great pathophysiology examples there, but don't worry too much about that. But essentially, if it's a big lesion, it can be cyanotic. Hopefully that answers your question a little bit. If anyone's got any questions, it doesn't need to be about this case. It can be just about OSCEs in general. And also, if you want the slides, please just feel free to email me. I can send them to you. I've put a link to the feedback form in the chat. If everyone could fill that out for us, that would be really helpful. Yeah. Any questions, feel free. Are there anything else you'd like to mention, Graham?
No, I think it's actually a really, really good, very good presentation. Good for my exams. The only kind of a couple of minor things, just in terms of the single palmar creases, it would be very, very unlikely to just get that as a single
definitely
of something like Down syndrome. You can get something called like mosaic Down syndrome, where you only get some of the features, but you would, all of the children with trisomy 21 that I've seen have multiple features, and it usually is relatively obvious. I think something's definitely gone wrong if a child has got to 5 months of age and no one has picked up on that. Just in terms of like in OSCEs at the end, so all babies get an examination before they leave hospital, if they're born in hospital, or if they're born in the community, they will get an examination within the first few days of life at home. And then they have their 6-week check by the GP as well. So they have those two kind of screening examinations by doctors or trained midwives. So I suppose what one of the OSCE scenarios could be that you are in a GP practice and you're completing a newborn check at 6 weeks. So in terms of like congenital conditions, that could be a station. I went to Manchester, and my PED stations were, one of them was a non-accidental injury scenario where it was a 6-week-old baby, and the parents had said that the baby had rolled off the cot and onto the floor. Just in terms of like potential stations that you guys might get, and you effectively needed to know that babies at 6 weeks can't roll. It's generally about 3-4 months or a little bit later. And
that's very tricky. Yeah.
It was a difficult station, but it was more just about your, communication skills and talking through the parents and, telling them that they can't leave hospital, things like that. And yeah, so just like what Steph was saying in terms of the ECG, if you were thinking about like a congenital heart condition, you'd be looking for things like right ventricular hypertrophy, like axis deviation, absolutely. And then also in terms of the chest X-ray, if you're getting to the point where the baby is becoming cyanotic, you probably do have some evidence, some element of cardiomegaly there as well. And then if you've got signs, so if they're tachypneic, then again, there's probably some kind of heart failure going on as well. So you might get things like, pulmonary infiltrates or signs of heart failure on that chest X-ray. That's all stuff you probably don't need to know for your like 4th year OSCE. Generally, what I would say, even as an F1 and as an F2, and even after that in pediatrics, you're very, very protected. And the main thing that you need to do is just, if you're worried about a child, then escalate. I would say that would be the main thing.
Yeah, I should put that in part of the management, actually. Yeah, it's a really good point.
Absolutely. Because, that's you as a junior doctor, you're kind of there to notice a very unwell patient, and you can implement the first parts of management plan, but then escalating early, especially in children, is very important. But yeah, but really, really good presentation.
Thanks. Oh, one thing I thought to say was the importance of the fact that the mother was overweight was just that it makes it very hard to image the heart in antenatal screening. So that's why it was missed, in case anyone spotted that. that was all I was getting at there. Otherwise, I think we can just finish things here. I don't think we've got any more questions. Ahmed's really kindly put in the chat a bit more of an explanation for ABSDs and things.